Hi, hello, good morning, good afternoon, everybody. My name is Rafał Ziecina, and I'm medical lead for cardiometabolic team at Worldwide Clinical Trials. The last American College of Cardiology meeting has just finished a couple of days ago, and it was another extremely successful meeting. We had a lot of great science discussed, and the results of many trials will be immediately implemented just to improve not only quality of life of many patients, but also just treatment of various comorbidities and mortality rates. And today I have with me a panel of truly distinguished scientists who just presented their studies at the Congress, and they will share the results of their studies with you. But we also want to look beyond 2025 and just understand where we are heading, what's going to be hot at ESC or AHA. So we have Dr. Bat from Icahn School of Medicine in New York at Mount Sinai. We have Dr. Anke from Charité in Berlin and Mark Bonaca from University of Colorado School of Medicine. And without further ado, I will just hand over to Dr. Bat, who will talk about results of REVERSE-IT trial.
Wonderful being with you. Thanks so much for having me. So let me just launch right in to keep us on time. Really happy to provide a recap of the main results of REVERSE-IT. Next. These are the disclosures for the authors. Next. The story for ticagrelor is an evolving one. It's a P2Y12 inhibitor that antagonizes platelet function and has been studied in numerous different trials with regulatory approvals across the world in a variety of different indications, and will be going generic worldwide soon. So the use of ticagrelor is already increasing and will likely increase even more. But like all antithrombotic drugs, all antiplatelet drugs, it can cause serious bleeding. And therefore, if one had a reversal agent, that would be a distinguishing feature among antiplatelets and potentially clinically useful. Next. Unlike other ADP-P2Y12 receptor antagonists, ticagrelor is reversible. By reversible, it doesn't mean it's out of your system in 5 minutes. Of course, its effect lingers for about 3 to 5 days. But in terms of how it binds to the ADP-P2Y12 receptor, that is reversible binding. And that has allowed the development of, next slide, a monoclonal antibody called bintrafimab. This is an intravenous Ig1 monoclonal antibody fragment that binds to free ticagrelor, also its active metabolite, with very high affinity and specificity. Next slide. It's already been studied in a phase 1 trial that I presented as a late breaker at ACC a few years ago. That work was also published in the New England Journal of Medicine. So phase 1, of course, means healthy human volunteers. And here we randomized these folks to either placebo or to bintrafimab and found an immediate and really effective degree of reversal of ticagrelor's antiplatelet effect. So in healthy human volunteers, work great. Next slide. Of course, then the question arises, how does it work in actual patients? And that's what REVERSE-IT was about, the phase 3 trial designed to evaluate whether bintrafimab actually reverses the antiplatelet effect of ticagrelor in actual patients, either patients undergoing emergency surgery or with bad bleeding. Next slide. And really great group of academic collaborators with respect to our steering committee, our data monitoring committee, our clinical events committee. Dr. Bonaca here was a member of our CEC. Next. And here's the primary endpoint, looking at percent inhibition of P2Y12 reaction units. It's a way of measuring platelet function and platelet reactivity, and compared to prior to dosing with bintrafimab, these ticagrelor-treated patients after treatment with bintrafimab had significant restoration of platelet function. You can see the p-value there and pretty tight confidence intervals. Next slide. So that's the overall trial. We also looked at several pre-specified subgroups, and basically the restoration of platelet function was significant compared with the patient's own baseline across all the different pre-specified subgroups. Next slide. And the secondary endpoint of the trial was hemostasis, and this is a single-arm trial. There was no randomization. Our investigators felt that they couldn't randomize, given that there was an effective, albeit unapproved, investigational compound that we knew from the phase 1 data reversed the effect of ticagrelor. So they didn't feel comfortable randomizing, therefore it was a single-arm trial. But to provide some objectivity to the assessment of hemostasis, we did have an independent CEC, and they adjudicated hemostasis. And overall in the trial thought that hemostasis was effective in 94% of the patients, 100% of the surgical patients, 83% of the major bleeding patients, 80% of the intracranial hemorrhage patients. Next slide. And in terms of subgroup analyses, very consistent effect across all the subgroups with respect to hemostasis. We used 50% hemostasis as the expected historical control. And with that standard, it looked like hemostasis was pretty effective across all these subgroups. Next. In terms of serious adverse events or serious adverse events leading to early termination from the study or termination of treatment, the safety profile seemed really good. No serious allergic reactions attributable to the drug, no serious thrombotic complications attributable to the drug. So overall, in the context of 200 or so patients, it seemed to be safe. Next. Limitations really are that there was no placebo arm. I mentioned why that was the case, although we do have randomized data from the phase 1 study. And as I mentioned, the sample size was modest, but it ended up being very well powered. Next. So in conclusion, eventrasumab significantly restored platelet function. Hemostasis appeared to be effective. No serious allergic or thrombotic or other adverse events that we could see. Eventrasumab, I'd say, appears to be a very promising option for ticagrelor reversal. It remains investigational, though recently the FDA did grant the drug orphan drug status. So that seemed like a promising step, but still a ways to go in terms of regulatory approval. So in a nutshell, that's the REVERSE-IT trial.
So thank you very much, Dr. Butt. And the one thing that was quite impressive when you discussed the study at the Congress was also that anecdotal evidence from like surgeons performing the procedure saying that, it's dry. So
Yes,
can you comment
absolutely. Yeah, great point. I mean, I generally don't like to veer into anecdote, but within the context of this clinical trial, single arm, the surgeons involved with the trial, I spoke to numerous investigators after the trial was complete, said when they operated on ticagrelor in real life, it was a bloody mess, but when they operated on ticagrelor on this trial, it was a pretty clean surgical field. So I do think that's a valid observation, a real observation, and is keeping with what happens to the platelets. I think if approved, this could be really useful in situations where having ticagrelor on board, like for emergency surgery or an intracranial bleed or something bad, could be really useful to be able to reverse it.
Great, thank you.
So I'd be happy to dive into the STRIDE trial. If you go on to the next slide. So this was a trial that was designed to look at the effect of semaglutide on walking capacity in patients with symptomatic peripheral artery disease and type 2 diabetes. It was a double-blind randomized placebo-controlled trial. If you go to the next slide. By way of background, peripheral artery disease is a prevalent and morbid manifestation of atherosclerotic vascular disease, and it's the most frequent first manifestation of cardiovascular disease or atherosclerosis in patients with type 2 diabetes. When we see patients who have PAD in the context of diabetes, it's really a tough clinical challenge. They tend to have small vessel disease below the knee, where we don't have great interventional options or medical therapies. And as a result, functional impairment and progressive decline is really a significant and dominant morbidity. We do have new drugs that were developed in the context of diabetes that have important outcome benefits, and those are recommended in the PAD guidelines, but neither of them are preferred on the basis of any PAD specific benefits. So they're recommended on the basis of MACE benefits or heart failure or kidney benefits. And so we don't know whether they have PAD specific benefits. And I think it's particularly important in the context of the the sort of unmet need. It's been 25 years or so since the last drug was approved for functional impairment in PAD, and you can see cilostazol was approved on the basis of a 40-meter treadmill improvement, but is really poorly tolerated in general. It doesn't have any cardiovascular benefits and is contraindicated in patients with heart failure. So it's not a great option for patients. Next slide. So this, it should be the design slide coming up. You can shift to the next slide. Great. So I mentioned the objective and the design schemas on the left. We recruited patients with symptomatic PAD, meaning they had claudication or pain with walking that relieves with rest, and diabetes. They were randomized in a 1-to-1 fashion to once weekly subcutaneous semaglutide or placebo. They were followed for a year. They had frequent clinical assessments, and we used the constant load treadmill, which is a very rigorous assessment of function. And they had that at baseline, 6 months, 1 year, and then 57 weeks, which is 5 weeks after the last dose of drug. You can see the inclusion and exclusion criteria on the right. We selected patients that had the sort of earliest manifestations of symptomatic disease, meaning they had claudication, but they could still walk 200 meters or more on a flat treadmill. They weren't severely limited. They did have to have some limitation, meaning a maximal walking distance of 600 meters or less, and they had an abnormal ABI. And they were excluded if they had an unstable cardiovascular condition or were planned for revascularization. Next slide. These are the baseline characteristics of the population, and I'll just point out that when there have been a lot of trials looking at GLP-1 agonists or other weight loss drugs, and this population is a bit lower in body weight. So one of the questions is the influence of body weight, but we had about 30 to 40% of the population here with a BMI less than 27, and the median was around 28. We had a lot of smoking. So if you see these patients, you realize smoking is an important risk factor. So about 2/3 were either prior or current smokers. And the background medical therapy was very good. Their LDLs were about 69 milligrams per deciliter, and there was high utilization of indicated medications as listed on the bottom of the slide. Next slide. This is the PAD and functional baseline characteristics. In blue, the semaglutide, and gray, placebo. You can see the ankle brachial indices were abnormal at around 0.79 or 0.76. I think what was most striking is despite the sort of desire to recruit early stage PAD, these patients were actually severely limited. So despite early stage symptoms, their maximal walking distance was about 184 meters or 1/10 of a mile, and the pain-free walking distance was much less than that. So they could only walk 1/10 of a mile without having to stop and rest or wait. And that was reflected in their assessment of their own quality of life, where you can see on the right, 2/3 had described a moderate or severe impairment in their walking ability, and almost all had some impairment. Next slide. So this is the primary outcome of the trial. On the left, this is ratio to baseline of the maximal walking distance. In gray, you can see the placebo arm. People in placebo got better. In part, this was because there was more drop-in of revascularization and other therapies. In part, it may be a learning effect on the treadmill. In the blue, you can see semaglutide, and there was a significant improvement in function apparent at 6 months, and the curves continue to diverge over time. On the right side, you can see the absolute differences, and probably the mean difference is the most meaningful in the context of prior studies that have used mean. So that's around a 40-meter net improvement, which is large. This is on the treadmill. Generally, we would consider 20 meters on a 6-minute walk test as clinically important. This is double that, and on a 12% grade. And then the anchor measure that was nested to determine clinical meaningfulness at the bottom there was highly statistically significant, meaning there was a change that the participants felt was clinically meaningful. Next slide. We looked across various subgroups. There was consistency effect for all of them: age, sex, region, A1C. And I think importantly at the bottom, even those with a lower BMI had the same benefit. And so we'll get into a little bit of what may have mediated this, but even in patients with a relatively normal BMI, there was no difference in effect. Next slide. We looked at other biomarkers of changes, and as you'd expect, blood pressure went down, A1C went down. There was a net decrease of 4 kilograms. We looked at the relationship between change in weight and change in maximal walking distance. It was actually apparent in both arms. So there's a very weak relationship between weight loss and function in this population, but the magnitude wasn't sufficient to explain the benefit that was observed in the trial. So there's some minor component of weight loss, but the benefits were driven by other factors. Next slide. And then across all of the primary and secondary outcomes, we saw statistically significant improvements. And just to summarize, patients functioned better. They felt better. Their symptoms were improved as measured by the pain-free walking distance. The quality of life improved using 2 different validated measures, and their hemodynamics improved as measured by the ankle brachial index. So patients felt and functioned better, and there was an improvement in this biomarker of hemodynamic compromise. Next slide. And then, although this was not powered for clinical outcomes, we did look at the composite of these pre-specified or prospectively collected components. So there was rescue initiation, meaning a revascularization procedure, major adverse limb event, or all-cause mortality. The rate was actually pretty high in the placebo group, despite it being a low-risk population. And you can see with semaglutide, there was a 54% associated lower rate of that outcome even at 1 year. And we'll talk a little bit about the SOUL trial later. And you can see the components there, small numbers, but all directionally in favor of the treatment. Next slide. So in general, we know a lot about GLP-1 agonists and semaglutide. There's a lot of known benefits on the left side of the slide. STRIDE adds that it improves function in a clinically meaningful way in patients with symptomatic PAD. It improves their quality of life, reduces disease progression, improves AVI, and I didn't show the safety data, but it was consistent with all the prior trials, much larger, longer follow-up. And so we know that now semaglutide improves function, symptoms, hemodynamics, and quality of life, as well as reduces progression to requiring rescue in patients with symptomatic PAD. I think that's my final slide, so thank you.
All right. Raphael, you're muted.
I have 1 or 2 slides on SOUL trial, so we will probably discuss both together. And I try now to maybe share the slides from Dr. Anker. So Heather, can you make me a presenter, please?
All right, why don't I start talking already? A FAHF2 trial is a trial of intravenous iron in heart failure patient with a reduced ejection fraction. And basically, this is an investigator initiative funded by the German Cardiovascular Research Foundation and some additional funds from a sponsor. And the idea was, next slide, to investigate in 1,105 patients the outcome of giving them ferric carboxymaltose. Next slide, please. You think we can move to the next slide? No worries, I can continue anyway. So 1,105 patients were included to investigate the reduction of cardiovascular mortality and heart failure hospitalization outcomes. And the investigation was in patients with an average age of 70 years. 2/3 were men, diabetes was present in 45% of the patients, very well treated with guideline-directed medical therapy. And the patients had a mean hemoglobin of 12.5 and a transferrin saturation of about 18. I don't know whether you see the next slide. I don't see the next slide. Okay, well, yeah, if you go back 1, please. I don't know. Sorry, can you go back 1? I see the 4th slide now, and maybe the 3rd slide would be more helpful. Yes, so we have three primary endpoints. Cardiovascular death and heart failure hospitalization is the first. The second primary endpoint is the recurrent rate of heart failure hospitalization. And then the third primary endpoint was in the subgroup of patients with a transferrin saturation less than 20% to investigate the primary endpoint again, because transferrin saturation less than 20 is considered a better kind of definition of the iron deficiency presence. We use the Hochberg procedure for combining these. Next slide, please. The primary endpoints number 1 and 2 are shown here, and the cardiovascular death and heart failure hospitalization reduced by 21%, a nominal p-value of 0.04, but by the Hochberg procedure, that is technically speaking not formally significant. On the right-hand side, you can see the total heart failure hospitalizations reduced by 20%, and the p-value for this is 0.1. And if you go to the next slide and show this, I think it was before better. At this moment, it's very small. Basically, in the subgroup of patients with a transferrin saturation and less than 20, if we go to the next slide, you basically see that there is a 21% benefit. And as you will notice, the 21% benefit, I'm sorry, it's really not moving forward, and I don't know why. The 21% benefit in the subgroup of patients with a TSAT less than 20% was not better than the overall definition. So if you take the summary as shown here, we have 20 to 21% reductions in the events, nominally but not formally significant by I think the previous version was better. This trying to show the presenter mode isn't helpful, honestly. But basically, this is telling us that the study overall, in line with previous trials, was reducing events. Now, the important thing, and this is slide number 7, please, is that the iron dose we're giving is particularly high in the first year. And in the first year, we are giving 2,000 milligram on average. In the second and third year, we give less. Next slide, please. And because of this, and because of a documentation that the results are in line with previous studies, we performed a meta-analysis. The trial for HF2 was published in JAMA, but the meta-analysis published in Nature Medicine, combining all the 6 available trials with 7,200 patients. If you move to the next slide, the primary endpoint there was the recurrent events of heart failure hospitalization and cardiovascular death, showing a significant reduction in the Bayesian statistic meta-analysis, reducing events by 19%, using a very conservative sensitivity analysis, still the same result and showing significance. Next slide. If you restrict the follow-up to only 12 months, where we give the highest dose, then actually you have a 28% reduction of recurrent heart failure hospitalizations and cardiovascular death, a very significant result clinically, but also statistically. And then the last data slide, next slide, is showing the interactions in this meta-analysis where we had very similar statistical approaches for all the trials. We basically were able to show that there is one subgroup highlighted here, the women versus men sex interaction, showing a significant interaction. Men do get a strong benefit for events, women don't. All the other subgroups analyzed in all the trials in a similar way, TSAT, age, New York Heart Class, showing similar overall results. Why there is this lesser effect in women, we don't know. If you allow me to summarize, next slide. Basically, the FAHF2 trial showed results that indicate event reductions, but by itself, the trial was not significant. The trial also confirmed the benefits on quality of life and patient global outcomes. We have now a second definition for iron deficiency. And next slide, with the Bayesian statistic meta-analysis, we can basically show, next slide, that the overall results are showing clinical significance for the patients. Thank you so much.
Thank you very much, and apologies because when I was going into the presenter mode, there's been some problems.
Yeah.
So Heather, can we just now move to other slides? Yeah, so I would probably go quickly through, we'll start that rapid fire roundtable discussion. And if we can go to the next slide, please. And when Dr. Bonacca presented his study, I think that there was the following presentation done very nicely by Dr. Maguire, who presented results of SOUL phase 3 trial. And there was a trial looking at the cardiovascular efficacy of oral semaglutide in patients with type 2 diabetes and atherosclerotic vascular disease, chronic kidney disease, or both. And they were specifically looking at the 3-point MACE. I think they used 3 doses. Oral semaglutide was up titrated from 3 to 7 and 14 milligrams. And all the patients were all the standard of care in terms of the glucose lowering therapies and risk reducing therapies. It was a large study. I mean, the baseline characteristic, very basic baseline characteristic is here. More than 9,500 patients, and they were in the follow-up for more than 4 years. Just a reminder, patients were eligible if they were above 50. They had confirmed diagnosis of type 2 diabetes mellitus, HbA1c between 6.5 and 10, and one of the additional cardiovascular risk factors. And if you can go to the next slide, please. When you look at the results and the analysis of the primary endpoint, there was quite impressive reduction. There was a 14% relative risk reduction in semaglutide arm as compared to the placebo. And those curves were statistically, probably there was the separation of curves starting around 6 months. But what also was very interesting for this study, that it had that 3 confirmatory secondary outcomes, but there was the hierarchical analysis of those outcomes. So unfortunately, the study failed on the first, which was the major kidney events. And the other 2, cardiovascular death and major adverse limb events, were just really analyzed as an exploratory analysis. But when you look at what's been shown for major adverse limb events, there is a really striking 29% relative risk reduction between the oral semaglutide arm and the placebo arm. What's also interesting is probably that we see a bit of the separation of curves from months 24 onwards, but there is really very impressive reduction in the number of major adverse limb events, which is in line with Dr. Bonacca has just presented. Of course, we don't have the p-value because there was the exploratory analysis only, but really, Mark, would like to hear a bit more from you about, those 2 studies and what would you think where we are heading and what's the future of the vascular medicine and what else has to be learned here, really.
Sure, I'll give a couple of comments. It'd be great to hear from Dr. Bhatt and Dr. Ankur as well. But I'd say that the story for the GLP-1s has been quite remarkable. And, the genesis for STRIDE had been, in part a subgroup analysis from the LEADER trial. It was a different drug, it was liraglutide, but there was this signal for reduction in amputations related to small vessel disease and diabetic foot ulcer. That was a published paper. And so there's this hope that these were vascular drugs. Now we've seen the SELECT trial where we saw cardiovascular benefits, MACE reductions, including in patients with peripheral artery disease. And we had hoped that that would extend to limb vascular benefits, especially in patients at high risk for small vessel disease or microvascular disease, very hard to treat. And so I think that the combination of STRIDE and SOUL really do provide further evidence that there are direct vascular benefits, that even in patients that aren't obese, we see effects on ABI, progression to requiring revascularization, and then the major adverse limb events in SOUL. And if you look at the definitions that were utilized in SOUL, those were hospitalizations for limb outcomes. And there's a lot of limb outcomes that happen outside of the hospital. I think it probably even underrepresents the magnitude of benefit. But I think, looking at the totality of the evidence, then I do believe these are vascular drugs, and I think really a game changer in patients with peripheral artery disease. Now, the functional benefits we observed were in patients who also had diabetes, but in the SELECT trial, the MACE benefits, extended beyond that into patients with PAD without diabetes. So you can use these drugs, and I think there's sort of immediate clinical implications to these observations because the drugs are available. there are a host of indications that could be prescribed under it. I hope there's an indication for function in PAD, because I think it opens a therapeutic pathway that maybe this is the beginning of really understanding, novel mechanism to improve these really morbid and debilitating outcomes. But yeah, love to hear from others too.
I congratulate you, first of all, on STRIDE. I think that was really a landmark trial, not just with respect to GLP-1 agonists, but just with respect to PAD and having a new therapy. So really remarkable results. And in that context, Rafal, to answer your question, I do think this finding from Seoul is real with respect to limb events. One can argue about statistical hierarchies and p-values, but looks like a real finding to me. And having the two data sets showing very complementary results for a particular drug, granted a slight difference in the route of administration between the two, but basically, supporting semaglutide and more broadly the concept of GLP-1 agonists. Of course, not all GLP-1 agonists are created equal. Not everyone's shown cardiovascular benefit, but certainly for ones like semaglutide and liraglutide, really great data. And I think now we can say they reduce MI, stroke, and limb events. So complete atherosclerotic protection.
If I could add, I mean, Seoul used 14 milligram semaglutide oral, which you might argue is around a sixth to a tenth of a proper weight loss dose that you want to use with injectable kind of semaglutide. So this is really the drug, and not so much the massive weight loss you can achieve and the risk factor modification that you dramatically can achieve. Maybe there is a small degree of weight loss also with this lower dose over the longer periods of time, maybe. But this shows us that, yes, these are vascular drugs.
Yeah, it's great because, I mean, Mark, you also showed the reduction, improvement in ABI. So this is another finding, which is how do you explain that? I mean, that's extremely powerful.
Yeah, I did a lot of reading around sort of the historical looks at ABI and things that may modify hemodynamics. And, I think what caught my attention and what was really our hypothesis going in is that there's a clear inflammatory role of progression of PAD. And in fact, I was speaking with Mark Krieger the other day about when you look at some of the imaging around these patients, you see a lot of inflammation around the blood vessels. There was a great piece written by Will Hyatt, actually, in Circulation Research that talked about the role of sort of perivascular vascular inflammation and in the hemodynamics. And so my guess here is that this is not a plaque regression effect, but it is more of an anti-inflammatory effect that's impacting maybe the small vessels and then improving hemodynamics. And some of the observations from the coronary CTA studies, Matt Budoff's studies, support that, I think, as well. Now, that's a guess. I think we need future studies to prove that, but I do think it raises the potential for the anti-inflammatory therapies that are in development to have potent PAD effects. If I had to guess, these folks had LDLs that were low. This was an LDL lowering effect. There was no effect there. It may have stabilized plaque, but I don't think that explains the ABI increase. I think it may be an anti-inflammatory effect.
Right. So can we move on? Because that would be nice to really spend the last 25 minutes discussing that, but we have a couple of other studies that, Heather, I mean, if you can just share the screen again. And I really want just to show 3 studies targeting dyslipidemias. I think we have an update for Alpaca trial, and this is the phase 2 trial with small interfering RNA targeting Lp(a). So these are the patients who are enrolled into the study with higher Lp(a) levels, and the study is looking at the safety and efficacy of lepodisiran. And patients were randomized into 3 different doses of lepodisiran or placebo. And 16, 96, and 400 milligrams were given twice on day 1 and day 180. And there was another arm looking at the single administration and 400 milligram dose only on day 1. And this is still phase 2 study. The phase 3 are ongoing, but that's 320 patients. And now we saw data from day 540. In order to be eligible, subjects must have been more than 40 years of age and pretty high Lp(a) values above 175 nanomoles per liter. And patients could have been on the standard of care, other lipid-modifying drugs, but they must be on a stable dose. So when we look at the second slide, please, for that study, and I only picked up the really data for the Lp(a). I think when we look at the highest dose, this is really the bottom curves of that top line graph, we saw almost 94% reduction from day 60 to 180 in a group that received the single dose of 400 milligrams. And in that group, the reduction in Lp(a) goes down to about 88.5, still pretty impressive between days 30 and 360. However, if those patients are getting a second dose on day 180, the reduction in Lp(a) between day 30 and day 360 is about 95%. And of course, the study has been designed in a way that only 2 doses can be given. Those patients are now in the long-term follow-up, and larger phase 3 are ongoing. But it is a pretty impressive drop in the Lp(a) level. And also, I put that, and I would probably ask also all of you to comment on that. I put also some changes in terms of the ApoB, because we know that maybe they are not as high, but we know that it's a very atherogenic and the event-generating particle. So when we look at that higher dose, where the patients received 2 injections of 400 milligram dose, there was a 15.5% reduction in ApoB on day 240. So I'll go through 2 more trials, and we'll talk about all of them in a sec. So if we can just go to the next one. The next one I wanted to bring to the discussion was Pursuit trial. This is the phase 2b trial looking at the oral PCSK9, and they are targeting patients with hypercholesterolemia. Patients been received to 4 different doses of active treatment and placebo. Again, phase 2 trial, so 428 patients in the follow-up. But what's important here is that 40% of those patients are on moderate dose of statins and 60% of high-intensity statins. And just the key inclusion criteria in order to be randomized, LDL-C must be between 70 and 190, with triglycerides being less than 400. And as I mentioned, they all are on either moderate or high-intensity statin. And when we go to the next slide, this is really a single dose of the drug, and we're looking at week 12 data. And in all these patients, there is a dose-dependent significant reduction in LDL-C level. But when we look at the highest dose, the drop was above 50% at week 12. And this is, as I mentioned already, on top of moderate or high-intensity statins. So 30 milligram group, that drop, in my opinion, is quite impressive. And the last study I wanted to share here would be, go to the next one, that's ARCHES-2 trial. That's another siRNA study looking at targeting ANGPTL3. And this is also phase 2 study, so 200 patients. We are looking at safety and efficacy of zodisiran. Patients in this study are getting 3 doses of zodisiran, 50, 100, and 200, and placebo. And in this study, they were getting 2 doses, one on day 1, one on week 12. Primary endpoint being evaluated at week 24, and patients were followed for 36 weeks. Here, the fasting triglycerides level should have been like between 150 and 500. LDL cholesterol for the patient to be eligible must be above 70, or non-HDL above 100. And they were pretty much all of them were on the stable dose of statin, 96% in the trial. And when you look at the results from the study, and go to the next slide, Heather, please. I put again 2, that's a change in triglycerides. That was the primary endpoint. And we see quite impressive drop at week 24. It's about 63%. And those differences are maintained until week 36. But also on the highest dose arm, we see quite significant drop in ApoB level, about 22% at week 24. And of course, we see on the small graph is showing the drops in ANGPTL3 levels. We know that the drug works. So really the 3 trials, and I know that there's been 2 more trials, the one looking at solbinisiran, the other one SHR 1918, also targeting ANGPTL3, and they also showed quite potent effect on LDL-C lowering. But just really would like to hear a bit more from you, where the field is heading at the moment, what trials we should really look into at ESC, AHA, and what's going to be the future of lipid-lowering therapies. And maybe, Deepak, you want to start with first.
Sure. I mean, really 3 innovative trials. I'll start with my comments about Alpaca first, an impressive result there. Before launching into that, I'll just say that Lp(a) is certainly hot right now. It's an independent risk factor for heart disease. That's very clear. Certain guidelines, such as from the European Society of Cardiology, the US-based National Lipid Association, say to check in all adults. I think that's good advice. I've been following it for a number of years, and even predating that, had been checking in folks, for example, with premature atherosclerosis, and found pretty high levels of Lp(a) in many of those types of patients. Probably 20 to 25% of people have elevated Lp(a). So I think that we'll find out in ongoing trials whether reducing Lp(a) reduces cardiovascular events. But to date, the epidemiology certainly suggests that it should. The genetics suggest that too, but you never know until you do the large outcome trials. But in terms of the phase 2 trial, Alpaca, very impressive results, almost 100% reduction in Lp(a) levels, and a very durable mechanism of action with the siRNA, the effect lasting out to at least 6 months, but maybe allowing every 6-month dosing, possibly even once a year dosing. So super exciting compound. Of course, have to wait and see what it looks like in phase 3. With respect to Pursuit, another phase 2 trial, in this case looking at an oral PCSK9 inhibitor, very exciting. There are other oral PCSK9 inhibitors as well, but the idea that you can get a 40-50% reduction in LDL cholesterol with an oral agent and not need an injectable, could be quite appealing. On the other hand, with respect to the injectable PCSK9 inhibitors, the monoclonal antibodies already have outcome data. Inclisiran is amassing outcome data with several ongoing trials, 2 in secondary prevention, 1 in primary prevention, and many others sort of in adjacent areas. So with that bulk of trial information to come, if that approach reduces actual cardiovascular events, well, then you might have an agent, while it's not oral, can only be given a couple of times a year and might help with adherence. So we have to see how all the phase 3 trials play out, and by phase 3 I mean specifically cardiovascular outcome trials play out, and how the orals will compare with the injectables, in particular the injectables where you can dose them like inclisiran every 6 months. And then the final trial you mentioned was Arches 2, looking at ANGPTL3, and once more seems to be really promising data, a large reduction in triglycerides, also a reduction noted there in ApoB. And once more, just have to see how that plays out in terms of actual clinical events, but certainly in terms of biomarkers, appears to be quite promising.
Mark, any comments from your side? I think, how high you really need to, how high Lp(a) must be to target it.
Yeah. Well, I agree with all of Dr. Bott's comments. I won't restate those. I do think for Lp(a), as you note, this is elevated. It's a genetic factor. It's elevated in a proportion of the population, but how much Lp(a) is bad or needs to be lowered, depending also on whether you're a healthy patient or patients with complex vascular disease, that's yet to be determined. Certainly in the LDL world, we went from giving 4S to lower is better and lowest is best. Perhaps that's the same for Lp(a) too. I think there's a lot to learn there. But as Dr. Bott said, I think first we need to know whether lowering Lp(a) is beneficial. And then, I think it's quite unusual to have a medication or therapy, as was shown, that essentially erases a risk factor, that it's not just lowering, but it's like a 99% reduction over a long period of time, which is really exciting. So if it works, we should really see pretty dramatic benefits. As I look at the other trials, as I look at the oral PCSK9 and the ANGPT3, I mean, it's all interesting that it used to be just give a statin because that's all we had. And now I think we're looking much more to a future of tailored therapy and personalization of lipid management. We're not going to give all of these drugs to everyone. If you don't have LPA, you're not going to get that. And remnant cholesterol may be more important for different disease states. In fact, there's some data for peripheral artery disease that it may be a particularly bad actor. And so I think it's going to get more complicated in terms of what we give each individual patient. And I think that also branches into implementation, just as Dr. Bott said, that you have these two areas where you have now growth of long-acting injectables where people can come in every 6 months or maybe a year to get their treatment for cardiometabolic risk factors, lipid risk. You also have orals, and those orals, small molecules can be combined with others where it could be sort of a poly pill for lipids, if you will. And so I don't think either one of these necessarily is going to dominate. I think what it means is that we have options for our patients, which is really good news because we don't do a particularly good job when you look at populations at lipid modification. And some of that is sort of meeting people where they are. And some are going to be willing to take injectables, some orals. And I think it's going to be great to have those options. Hopefully the phase 3 data, as Dr. Bott said, the outcomes data support, all of these mechanisms and we can do better for our patients.
I think actually the interesting thing here, and the same is happening in the obesity world, having options for the delivery of a good medicine, long acting daily medicine, weekly, half yearly is happening in obesity. Now you have here similar kind of situations. It will, of course, at some stage, the question will come up, okay, who's better than who? And then you will talk about competitive studies. And if you have different routes of administration and different kind of schedules of administration, that of course may make blinding rather difficult.
Yeah, and also, I mean, I don't know what you think about the ApoB changes. I mean, I was like trying to show two graphs because those changes may not be like 90%, but they are pretty significant, and that they also like think they are having effect.
Yeah, well, to me, I have a just philosophical kind of thinking there. Why did nature invent ApoB if it's not good for something? And so is 99% reduction really maybe the best? I don't know.
Okay. And what shall we look? I know that we are looking into horizon readouts, correct? In terms of the LP is probably the first phase 3 trial, but I think that it is now 26. What would be, in your opinion, what should we look at ESC and AHA later this year?
Well, I think we should look to see what the results are. I mean, it depends whether there's a significant reduction in cardiovascular events or not. If there is, then we'll have a new therapeutic. We'll have to figure out exactly how to integrate it into practice, of course. But and if we don't have positive results from the current LP lowering trials, you have to really go back to the drawing board and think, why is that? Is it the specific approach? Is it the specific dose? Is it the specific population? Is it specific endpoints that we looked at? Very clear associations, for example, with MI and Lp(a), but stroke, it's a little bit more all over the place. So, I think that we're at the beginning of the whole Lp(a) journey. So I hope that the ongoing trials that look at cardiovascular outcomes are positive, but even if they're not, or even if they're positive, but weakly so, it doesn't mean, I think, that investigation along this line should cease, because it can take a lot of effort to tease out the relationship between risk factors and finding effective therapeutics. LDL at this point, extremely well validated as a target, multiple approaches that work well, obviously, statins, but ezetimibe as well, bempedoic acid, and of course, PCSK9 inhibitors, and different types of PCSK9 inhibitors, it seems, are likely to affect cardiovascular events. So to me, that story is very well written. We're still learning. We still don't know just how low we should go. I mean, it's interesting to hear Dr. Anker talk about potential utility. Why is all of this cholesterol and so forth existing? But, I'd say with LDL cholesterol, at least, and ApoB would be then related, the levels in urban populations throughout the world are way higher than what's normal. a normal level is much lower, say maybe around 20-ish to 30-ish milligrams per deciliter. So certainly in urbanized populations in particular, well, I won't even say Western urbanized, just in urbanized populations, south of at this point, what is a quote unquote normal or average cholesterol, in fact, is too high and pathological. So I think that's the explanation that you just need to sort of reset our belief of what's normal. But, with respect to other sorts of risk factors, HDL, that's been a very complex story with no clear therapeutics that are effective at targeting HDL in the modern statin era. And triglycerides have, of course, been a very confusing story with fibrates in the modern era not showing any cardiovascular benefit. Mixtures of omega-3 fatty acids not showing a benefit, but purified EPA or icosapent showing benefit. And I think LP(a) likewise, we're at an early part of the journey, so got to wait and see.
Can I make a short comment? I said I don't know why ApoA is there. For cholesterol, I think we have an idea why it's there. First of all, you need cholesterol for the anabolic steroid synthesis, but that's only a small amount you need for that. But cholesterol reflecting nutrition is a major factor, and now we're talking many thousands or more years back for surviving infection. And basically, nature is not about becoming 70 or 80 years old. Nature is about surviving birth or injury when you're about 20 and you want to reproduce. And in that phase, lipids bind to endotoxin. And actually, we published on this in the 99 and 2000 in Lancet. So if anybody's interested, the lipoprotein endotoxin hypothesis is in that setting quite interesting.
So excellent comments. And I also still have two trials that I wanted to bring to discussion here, especially Dr. Anker's comments. So Heather, can you show two remaining studies? Yeah, so I think that the first one is really the study that's been presented last year, and this is Summit. This is the study looking at patients with HFpEF and BMI above 30 kilograms per square meter. And the study population we know was enriched with patients with CKD, and about 60% of patients had eGFR more than 60. And those patients were really treated with placebo and tirzepatide for a median of 104 weeks. And when we look at patients with CKD, we know that they had greater severity of heart failure, and that was reflected by worsening functional class, KCCQ scores, 6-minute walk distance. They had higher levels of NT-proBNP, troponin T. They had twofold increase in the risk of worsening heart failure events. However, when the analysis was done, CKD did not influence the effect of tirzepatide to reduce the relative risk reduction of major adverse events. However, that when you look at the absolute risk reduction in the primary events, was numerically greater in patients with CKD. But when we go to the next slide, and this is the data presented by Dr. Packer, and it can go to the next slide, Heather. On the right-hand side, I think it's becoming really interesting when you look at the changes in GFR evaluated by creatinine and by cystatin C. So when the data from Summit's been analyzed, and as compared to placebo, and based on the eGFR creatinine treatment, treatment with tirzepatide was accompanied by a significant decrease in GFR at week 12, and then followed by a significant improvement in GFR at week 52. When the same analysis has been done with cystatin C, the initial decline in the eGFR was much smaller in magnitude, and there was the much pronounced improvement at week 52. So I will just come back to that in a second, but I want to introduce the one more trial that we can talk about heart failure in total. And the second trial was really the CardiAmp trial that looked at the allogenic stem cell therapy in patients with HFrEF, and there were patients with ejection fraction 20 and 40, New York Heart Association class 2 to 3, and 6-minute walk distance between 100 and 450 meters. The study enrolled only 115 patients out of 250, so maybe wasn't powered enough, and had quite complex analysis of the primary endpoint. But when you go to the next slide, Heather, please, it missed the primary outcome using the 6-minute walk test, but it showed very positive effect in patients with elevated NT-proBNP levels, and there was like 13% reduction in death, which was like the equivalent to 47% relative risk reduction. They had improvement in the quality of life scores. There's been various improvements. And we know that CardiAmp HF2 trial is actively recruiting patients. So the question here is, okay, should we, for the stem cell treatment or for the cell therapies, should we really target patients with HFrEF and certain NT-proBNP cutoff value? And just really would like to hear two comments. Maybe start with Dr. Anker. The first one, how do you really measure your eGFR in patients who are receiving drugs like semaglutide or tirzepatide, and then also what's the future of the cell treatment in heart failure?
Yeah, thank you so much. Well, there's a very simple answer. When you're giving drugs like semaglutide and you induce strong weight loss, measuring kidney function change over time with GFR is by far not the best method. Weight loss is also associated with loss of skeletal muscle, and that is basically always happening with all these drugs, and that basically leads to accumulation of creatinine. So cystatin C, I would strongly recommend if you want to assess specifically kidney function over time in patients with obesity therapy using GLP-1s and successful obesity therapies particularly, then really GFR is suboptimal. So I'm doubting whether there was even a decline in kidney function to begin with, because it was all about change in GFR. And to me, a change in GFR or a decline in GFR is an accumulation of creatinine, is a loss of skeletal muscle, can be a big confounder of these things. And I would put the hypothesis out, if you take an objective measure of kidney function, you might not even have a decline of kidney function in these patients. So this would be my main comment on the SUMMIT trial. Otherwise, I think it just confirms the multiple possible benefits of GLP-1 agonism and weight loss in heart failure patients. Kidney function is amongst these possible kind of benefits. And the second thing about the stem cell study, well, the first study was very small, only 115 patients, which I believe was less than originally planned. We see an encouraging post-hoc result. It's good that they are doing a second study. I would say let's wait and see.
Right. And any comments from Marco or you, Deepak?
Hard to argue with any of that. Sounded quite wise to me. With respect to tirzepatide, agree, more great data in general supporting that weight loss has benefits in heart failure with preserved ejection fraction, regardless of the mechanism of action. Tirzepatide, of course, leads to weight loss, may have some effects independent of weight loss, but more great data there. And with respect to cystatin C, I mean, there's already great data supporting that we should be using cystatin instead of eGFR, but nobody's doing it, I think, because of issues of practicality, but we probably should be doing it, especially as Dr. Anker points out, if there are going to be changes in weight, as there often are in real life for a variety of reasons. So yeah, of course, it would be better to use it. And as far as the second trial, agree, we need a larger confirmatory trial. Looks interesting, certainly piqued my interest, but obviously need a much larger number of patients.
Okay, Mark, and the last comment, because we are at the top of full hour, so
Sure.
I'll be just wrapping up.
No, I agree with all the prior comments. I'll just point out that FLOW was a trial with GLP-1 agonists in patients who did have kidney disease and showed dramatic benefits. So, I think that the measurement's one issue, I think, as Dr. Bott pointed out, but I think it's just another area where the GLP-1s have shown benefit, at least with semaglutide in that trial.
Right. So with that, I would like to really thank you very much. I think there was a very, very productive discussion. Thank you, Dr. Bott. Thank you, Dr. Bonaca. Thank you, Dr. Anker. And I hope that, we will continue in the future and maybe have another one. But once again, many thanks, and hopefully see you soon. Thank you very much.
Thank
Great.
you.
Thank you
Bye.
very much. Bye now.
Thank you.
you.
Bye bye.